So we need to adapt to the advancing technologies. Otherwise, like Darwin said, only the people who adopt to the changes will survive and the rest will perish. Going to talk on only tips and tricks where we can go wrong when we use robot when we do deformity surgeries. And the such complex surgeries require complex planning and execution, and robot is a very delicate machine, and when you use it for simple surgeries also you have to be very careful. Again, when you use it for deformity, it really throws up challenges to you. If you get very well versed with the robot, how to work around it, you can do good surgeries. So we know that it can do very accurate surgery, but it can repeat the same mistakes if you don't adopt to the robot. And it executes whatever you have instructed. So the planning is the crux here, and it doesn't get bored. It can do dull things again and again, and it doesn't complain. And the robot, what it cannot do is it cannot think for itself. You have to train it, and they can do only what you have planned. And this, it gives a false sense of safety. Apache is here, they have used the second generation and they know it. If you don't plan properly and execute the surgery properly, you can go wrong multiple times more than in conventional surgeries. So what are the challenges? That is to achieve accuracy, patient motion, to prevent the patient motion, platform stability is a challenge, planning is a challenge, implants are again a challenge, and anatomy, that is it can cause skiving or soft tissue and bony prominences. Where all we can face challenges? We can face challenges in positioning, especially we are having mounts, in planning process, execution process, the screws, rods and osteotomy and interbody work. So positioning, especially with robot, the most common error which you can have is the patient moving. When you do some push and pull, when you put screws, or when the robotic arm is moving, when you are dilating the muscles, you do push and pull. So there the patient moves. Then if the patient moves, then again your all accuracy is gone. So that is why you need to position a patient in a stabilized manner, strap them as much as possible, and just make the patient stick to the platform, that is your table. And especially Mesorex, because it is going to attach with the table, so you need to have a very stable table there. Comes to the mounts, which actually marries the robot with the patient, where it maintains the constant relationship with the patient. You have iliac pins, you have spinous process clamps, there can be single and double, and pedicle shank pins. What is the challenge here? Because the vertebrae are rotated, the iliac pin can come in between your screw trajectories. So plan in such a way and place the pin, if you are placing in such a way that it doesn't come in between your screw positioning. Again, the clamps, sometimes the spinous process is so much rotated, you are not able to place these clamps. So again, that's a challenge there. And in pedicle shank pins, you can break the pedicle if you move table, so you have to be very, very careful. When it comes to planning, the beauty of robot is this, because in deformity we are going to have a basically multi-rod constructs. We can have, there are n number of screws, many screws which have been put, which has to be aligned when we, especially when we are doing MIS deformity surgeries. So what happens, I'll just show you. This is how basically you can align the two lips. You see that on the left hand side, your rod is also moving along with your tulip. So you can, when you are doing a MIS deformity surgeries, you can align your tulips in a way that you can insert your rods properly. Next is the same thing when you want to create a lordosis, especially in adult deformities. You have to plan in such a way that the pedicle screws are placed in a way where you can achieve lordosis. You see the way, as the screws moves, the rod also moves there. So you can align those screws and then do this. The MIS deformity really it helps. And now the future is, it is coming, they are coming up with the machine which can pre-bend the rod according to your planning, and we know that pre-bend rods don't have that rod benders mark, and they are more basically stronger. Next is you can actually in adult deformities, now we are doing multiple olives. You can plan your olives properly and see for the basically interbody cage how much you want to put. Each level you can measure what amount of lordosis you want to achieve. You see, once we simulate the cage, you see that it shows how much lordosis you can achieve at each level. So that way you can plan your surgeries well. The same you can see, you can measure the curve angles, you can insert the cages and see. Once you insert the cage, it also depends on the cage insertion where you are placing the cage, whether you are placing the cage in anterior 1/3, in the middle 1/3, posterior 1/3. That way you can actually plan your lordosis achievement. Also, this beautiful thing is, when you have a very badly rotated vertebrae, you can correct the axis of rotation and plan your screws on the software. And if you have, especially in pediatric patients, it also warns if your pedicle screws are going to crash with each other. This is very important when we do MI surgeries. If you plan in such a way where, this is just an example, your all extenders, pedicle screw extenders are going to cross each other, and it's going to be very difficult to negotiate the rod through that. So plan the pedicle screws in a way where your pedicle screw extenders don't cross each other. It really helps again putting your S2I screws, pelvic fixations. If you have a stable construct, the deformity surgery really stays well. So this is one, I'll just skip this video, and this is just an example, and that is another example where the robotic surgery was done. What you need to do is, these are the trips. Basically, if you try to put the pedicle screws one after another and drill, you will create patient motion and motion errors. So whatever you have planned, drill first all the pedicles at once, and then put your pedicle screws into those drilled pilot holes. And always don't use any push or any force to drill the pedicles. So always use fine touch. High speed drill has really made our lives easier because it prevents the skiving. You can do it with 3-finger fine touch movement, which prevents errors. And whenever you have soft tissue pressure, look for that movement of robotic arm. That is another major error which can happen, and you might want to take extra incisions, especially at S1, L5 and end of the constructs. The causes of failure are basically the registration method. If you are doing a registration from CT to fluoro based registration method, what I mean is pre-op CT scan and intraoperative fluoro based registration. If your deformity is large, then it becomes difficult to register. Sometimes you won't be able to register, then you won't be able to execute your planning. So that is one of the fallacies. But if you have a OARM, the life becomes easier. And basically skiving is, again, it depends on your planning and also how you execute your drilling method, and high speed burr really helps there. And the soft tissue pressure is one of the most problematic thing, and wherever you feel that there is a high soft tissue pressure, you have to have extra incisions. Pitfalls in thoracic spine, especially where you have a completely Nash and Moe grade 3-4 rotations, your rib cage can come in between your trajectories. So that is where you, whatever you have planned, you might not be able to execute. You might have planned anatomical screws, but then your rib cage comes in between the drilling. So there you might have to maybe omit those pedicles, or you might have to use navigation, not the robot there. And especially end vertebrae, again there is a high soft tissue pressure. You might have to have extra incision, and movement errors are important. Thank you.